in a department where he works. No, honestly, you can go to YouTube and listen to his CNN interviews or his talks. He works on a broad field of inequity, of racism, poverty, and he's done seminal work with Ron Kessler and many other people on how that affects health, mental health, and well-being. He's both at the Harvard School of Public Health and, as you can see here, around the corner at the African American Studies. And I think, I wasn't sure, are you also at the sociology department? No, not anymore. Yeah, technically, he's also doing sociology. I can tell you very shortly, if you, for a few weeks, he moved office and I got his mail, and that is so much. It's unbelievable how he manages life. It's so much. That impressed me as much of his academic work. Stella. He's one of the few, no, seriously, he's one of the few voices in a very heated debate in this country, which I think stands for insight, quality, and growth, and is accepted across the lines. He's part of the National Academy. He's really a respected teacher and lecturer, and that's all I'm going to say. David, take the floor.
Thank you, Henning. It's an honor for us in the Department of Social and Behavioral Sciences to have Henning as our colleague here at Harvard University. So it's really good to be here with you today and to talk about effectively addressing diversity and inclusion. And I think to do that well, we need to talk about why we need to care about it in the first place. So I'm going to talk about why we need to care about it, half my talk, and then what can we do about it, giving you kind of high-level overviews. I mean, we could go into this for a semester on the nitty-gritty details. Socioeconomic status, or SES, as I often abbreviate it, whether measured by income, education, occupational status, or wealth, is one of the biggest predictors of variation in health in the world. Globally, that's true. And it matters profoundly for child health. I'm drawing on the work of Gary Evans here, who had a wonderful paper summarizing all of the research on the negative effects of being raised in poverty on children. Compared to higher socioeconomic status children, poor children, research shows, are exposed to more family turmoil, violence, separation, instability, and chaotic households. They experience less social support and have parents who are less responsive and more authoritarian. These are, of course, on average. They are read to less frequently, watch more television, and have less access to books and computers. They are less likely to have parents involved in their school activities. They are more likely to consume air and water that is polluted. They are more likely to live in homes that are crowded, noisier, and of lower quality. They're more likely to live in neighborhoods that are more dangerous, have poorer city services, and have greater physical deterioration. They are more likely to attend schools and daycare that are of inferior quality. So poverty then has a broad range of negative effects on childhood development. And race and ethnicity in the United States, and one of the things I'll do in my talk today is show you a few examples that this is not a US problem, it's a global problem, are strongly related to socioeconomic status. So here's one indicator of socioeconomic status, median household income in the United States. I'm drawing on data here from a 2019 report from the US Census Bureau, given the median household income by race. And I just put it in a way where you can't miss the point. So I'm standardizing on the household income of white households as $1. And for every $1 of household income white households receive, Asian households receive $1.20. To contextualize that data, keep in mind that almost 70% of Asians in the United States are immigrants, and they've come to the US with markedly higher levels of education, almost on average twice the levels of college completion as a white population, for example. More importantly for this statistic, Asian households compared to any other groups have more persons contributing to household income. They are more likely to live in multi-generational households than any other group. So that's the caveats to keep in mind. If we had a per capita measure of income, whites have the highest per capita per person measure of income. But let's look at the historically disadvantaged groups. In 2018, for every $1 of income white households earned, Latino households received 73 cents, and Native American and African American households received 59 cents. What is stunning about the 59 cents figure for Blacks is that it's identical to the Black-White gap in income in 1978. You heard me correct. I did not misspeak. I said 1978. The peak year of the narrowing of the Black-White gap in income as a result of the civil rights policies and the anti-poverty policies of the 60s and 70s, the gap was narrowed to 59 cents. And in 2018, it is still 59 cents. Has it been stuck at 59 cents through the years? No. It worsened throughout the decade of the 1980s. Reaganomics was not good to the Black community. And it was not until the mid-1990s it got back up to 59 cents, and it's been a penny up and down since then. The take-home point is, these data indicate that racial ethnic differences in income, but in economic status more broadly, are much larger than most Americans think. And we have made much less progress than most of my students think and most Americans think. So there are huge differences by income in the United States. And just to illustrate the point that this is a problem across multiple contexts, I think something happened in the translation of the slide, but you can get the point. Here's the median income by race in South Africa in 2014, 2015. The rand is the currency there. For every rand of income, what whites receive, Asian, which is mainly Indian, persons from India. South Africa has the largest Indian population outside of India, receive 60 cents. Coloreds receive 40 cents and Blacks receive 20 cents. The 20 cents is progress since apartheid fell. When apartheid fell, Blacks earned 10 cents for every dollar whites earned in South Africa. So the 20 cents is progress, but the point is there are striking, stark differences in income in another society. Let's look at the United Kingdom. For every pound of weekly income that the white majority earns, other whites, mainly Eastern European whites, is that category, earn 79p. Indians earn 86p, Pakistanis 57, Bangladeshis 52, Chinese 76p, Blacks from the Caribbean 77, Blacks from Africa 60p. So the point is, race captures inequities in income across multiple contexts. Here is one more example. This is the percent of the population that's low income for the Afro-descended population compared to the non-Afro-descended population in multiple countries in Latin America. Again, I think with this translation of the PowerPoint, some things aren't quite as they should be looking as clearly. But what you can see in Brazil, let me just go over Brazil and clear. So the Afro-descended population percent low income is 33. And for the African descended population, the non-African descended population is 16. So it's the higher levels of low income in the Afro-descended population in Brazil, in Ecuador, in Peru, in Uruguay, examples that this particular report I'm drawing on illustrates. Now, even when we focus on income gaps by race, we dramatically understate the racial gap in economic resources. And what I mean by that is that income captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. Wealth captures our economic reserves, our home equity, our investments, our savings, our checking accounts. And here is data from the Federal Reserve Board. For every dollar of wealth that white households have, a little slow in responded, Black households have 10 cents and Latino households have 12 cents. So very large racial ethnic differences in wealth. And if we go across the Atlantic, here are wealth by ethnic group in the United Kingdom. For every pound of wealth that white households have in the UK, Indians have 95 pence, Pakistanis 50 pence, Blacks from the Caribbean 20 pence, Blacks from Africa and Bangladeshis 10 pence. So again, I'm showing you across context where we have data by race. Many countries don't collect data on race. In some countries like France, it is illegal to collect data by race. You can't do a study and ask racial questions, or the government does not collect racial statistics. Doesn't mean there aren't racial inequities there, but we can't document them if you don't collect them. Okay, so I've shown you that poverty matters, socioeconomic status matters. I've shown you that race powerfully predicts variations in socioeconomic status. So not surprisingly, there are large racial ethnic differences in health in the United States and around the world. Here's infant mortality in 2016 in the US. And you can see the towering excess risk for African Americans and the Native American population compared to other groups. There's some complexities with the Asian and Hispanic data that these data don't reflect. If you look at the most readily available health outcomes, immigrants of all racial ethnic groups have better health than their native counterparts. White immigrants have better health than whites born in the US. Black immigrants have better health than blacks born in the US. Latino immigrants have better health than Latinos born in the US. Asian immigrants have better health than Asians born in the US. Across the board, there's a healthy immigrant effect with overall mortality data, with infant mortality data. That's the good news. The bad news is the longer immigrants stay in the United States, the worse their health becomes. You see dramatic deterioration in the health of immigrants with increasing length of stay in the US. Infant mortality by race in England. And you can see the white British, the white others, mainly immigrants. You can see they have low levels and the white British. Then blacks from Africa, blacks from the Caribbean, and Pakistanis, and most data, Bangladeshis are very disadvantaged too, but not in the infant mortality data. I don't have an explanation, have elevated risk. The point is, I'm looking at another society and you're seeing the persistence of racial ethnic gaps in health. Here is data from Latin America. This is again looking at the Afro-descended population in multiple countries in Latin America. And you can see in Costa Rica, Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia, not Argentina, you see the Afro-descended population having higher rates of infant mortality than the non-Afro-descended population. And if we look at the indigenous populations in Latin America, you see the same thing. In Costa Rica, in Uruguay, in Mexico, Colombia, Brazil, Venezuela, Peru, Ecuador, Panama, Guatemala, Bolivia, you can see the indigenous population having higher rates of infant mortality. So across multiple contexts, you see a similar pattern. And I have data from Australia and New Zealand, you see the same thing, but I don't want to bore you, get the point with data. And COVID-19 is worsening these large racial inequities in health. We are climbing towards 1 million deaths from COVID-19 in the United States. And I think Americans haven't fully realized the impact that is. Imagine if we lost the entire population of Alaska or Vermont or Wyoming or North Dakota or South Dakota or Washington, DC. More people have died from COVID than the population of any one of those states or the District of Columbia. And Blacks, Hispanics, Native Americans, and Pacific Islanders have had an age-adjusted death rate from COVID-19 that is at least twice that of whites. And you can't quite see the data. Again, there was something lost in the translation from one computer to the next. But what you're supposed to be seeing here is a decline in life expectancy at birth. There's a 3.7-year decline from 2019 to 2020 for Hispanic males, a 3.3-year decline for African-American males, 2.4 years, 3.4 years for Black females, over 2 years for Hispanic females, 1.2 years for white males, and 1.1 years for white females. So across the board, we see a dramatic decline in life expectancy. To put that into context, we have not seen declines in life expectancy of this magnitude in the United States since the early 1940s. During World War II, there was 1 year when there was a large decline in life expectancy. So this is historic, what we are seeing in terms of the impact of COVID-19 on the overall population health. But because the impact is disproportionate, in the United States in 2020, for example, although life expectancy has been slightly increasing every year, we have lower life expectancy than in 2010, than 10 years ago, because of the impact of COVID. What this low economic status means is, although we're all in the same boat of the pandemic, racial groups, we are on the same storm, sorry. We are not in the same boat because some vessels are better able to weather the storm than, in fact, others. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in socioeconomic status. So if you looked, for example, at Blacks and whites, at the same levels of income and education, race wouldn't matter. We now know that life is more complicated than that, and I'll show you just 2 data points on that. Here is infant mortality by mother's education in the United States. And you can see for any group, whites, as mother's education increases from less than 12 years to high school completion, some college education or more, you can see not life expectancy, sorry, but infant mortality consistently declining. And that's true across the board for multiple populations. You see the decline in infant mortality. You also see it for African Americans and Native Americans. But what you see is the very elevated level that still persists at even the highest levels. This is college educated or more African American women, and they have rates of infant mortality that are higher than that of many other women who have not finished high school. So yes, they're the best off, but they're doing so much worse than other groups. And just to give you another example of this phenomenon, this is work done by Sarah Burkhardt at the University of Michigan. This is South African data. And what you can see, they compare it to the Black population, is the comparison group. Colored, the Asian, and the white population have markedly lower rates of infant mortality. These are not, the other data I showed you were bivariate analyses. These are not bivariate analyses. This is the magnitude of the racial gap after she has adjusted for demographic variables and income and education and the number of children born. So after a broad range of social and demographic factors, we still see these striking differences in socioeconomic status. One more example, looking at data for Brazil. And what this shows is different racial groups in Brazil, the white, dark, mulatto, Black. And this is at different levels of education. These are mothers with no formal education, with 1 to 3 years, 4 to 7, 8 or more. And you can see a pattern again, increase in education, lower rates of infant mortality, but you see the stunning excess risk at every level of education. Race still matters profoundly for health. So why does race matter so much? And so I and other researchers for the last 25 years have been asking the question, could racism be a critical missing piece of the puzzle to understand the patterning of racial differences in health? When I use the term racism, I'm not talking primarily about the beliefs and behaviors of individuals. I'm talking about racism as a social system. I define it, borrowing on the work of Eduardo Bonilla Silva and others, that racism as an organized system. It categorizes and ranks different population groups. It devalues, disempowers some, differentially allocates opportunities and resources to some groups, and disadvantages to others. Central to racism is an ideology of inferiority, that some groups are inferior to others. It can lead to prejudice, negative attitudes and beliefs, prejudice and stereotypes to our groups, and the differential treatment by both individuals and social institutions. So I want to talk about a couple mechanisms by which racism operates to affect maternal and child health outcomes. And one I have studied is, and today we're using the term structural or institutional racism, is the role of residential segregation. In 2001, I wrote a paper with one of my former students, Dr. Chiquita Collins, arguing that residential segregation was a fundamental cause of racial disparities in health. And we are kidding ourselves if we will ever make progress in reducing disparities if we don't dismantle the structures that have been created by residential segregation. Why would we make such a claim? Well, residential segregation is an institutional mechanism or structural mechanism of racism. It's deeply embedded. It's as American as apple pie. It's deeply embedded in American history and culture. Developed in the late 19th century when the slaves were freed, has been stuck in place through the 1940s, was well developed by the 1940s, and although ruled illegal, the mechanisms that produced it in the 1960s with civil rights legislation, the structure that was put in place still persists. And I want to show you that structure and some of its consequences for child development. This is a book by a historian, John Sell, about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa got the idea of apartheid from America. That's one of the things we gave to the world, segregation. They saw it and they said, brilliant. we can implement that in our country, given how well it's working in the United States. Importantly, Sell argues that segregation is one of the most successful domestic policies of the 20th century in the United States. Why would he say this about segregation? What does segregation do? Well, imagine segregation as a burglar at midnight that enters a community. And once it shows up, valuables disappear, like quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and high quality transportation and access to healthcare. All of these factors vary dramatically by zip code in the United States, vary dramatically by neighborhood level, vary dramatically by place. Let's look at some data. These are two of Harvard's eminent sociologists, William Julius Wilson and Robert Sampson. They did a study of the 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of Blacks, and that the worst urban context in which whites reside is considerably better than the average context of Black communities. Paying attention, that's a 1995 study, so you say, well, how have things gotten? Are they better now? So I'm going to draw on the work of one of my colleagues, Professor Dolores Acevedo Garcia. He has created a child opportunity index, ranking every county in the United States on 29 different indicators of access to opportunity for children. Things like the quality of early childhood programs and the quality of elementary schools, things like the high school graduation rate in that community, things like the home ownership rate, median income level, employment rate, things like the quality of the environment, the air, water, soil, things like resources for health, like green space and healthy food outlets and so on. So 29 different indicators. These are just a few examples of, in the 5 categories that she has 29 indicators, and now she's ranked virtually every community in the United States on opportunity for children. And this is what she found. And this is a 2020 publication. So this is not ancient history. The 2020 publication, looking at the 100 largest metro areas in the United States. She asked who lives in the low or very low opportunity neighborhoods. 67% of all Black children live in very low or low opportunity neighborhoods, compared to, and also true for 58% of Latino kids and 53% of Native American kids, compared to about 1 in 5 white and Asian kids. Who lives in high and very high opportunity neighborhoods? Almost 2/3 of white and Asian kids and about 1 in 5 Black and Latino kids. So where you live for children in this country is a powerful predictor of access to opportunity that has dramatic effects on even the racial ethnic differences in income and education in the first place. In fact, research indicates that residential segregation, opportunities at the neighborhood level, is the driver of racial ethnic differences in income and education in the United States in the first place. Let me show you 2 studies. David Cutler, Harvard economist, using national data for the United States, using fancy econometric models that I cannot even fully describe, but he's able to show statistically that if you could erase residential segregation, eliminate it in the United States, you would completely erase Black-white differences in income, in education, and in unemployment, and reduce Black-white differences in single motherhood by 2/3. All of these striking differences are linked to not that Blacks are not working hard enough, but it's linked to opportunities at the neighborhood level. One more Harvard economist, Rash Chetty. He has done an intergenerational analysis, got census data for many years, and he's asking the question, let's look at Black and white children who start out life at the same level of household income. How are the children doing in the next generation? So he's taken income out of the parental income out of the picture. And what he finds, in 99% of census tracts in America, Black boys have lower income than white boys, even when you take into account their parental income. Why? They live in neighborhoods that differ in opportunity. When Black boys live in neighborhoods with good opportunity, they do as well as white boys. But remember, that's not true in 99% of neighborhoods in the United States. So what are we talking about then? The racial ethnic differences in income and education and other outcomes that we see that matter for life and health do not reflect a broken system. In fact, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. They are not accidents, they're not acts of God, they're not random events. They illustrate the ways in which racism's upstream structural effects have produced a truly rigged system in the United States. And segregation also adversely affects access to care and the quality of medical care. I'll give you one quick example. Looking at South Los Angeles, in LA County, elevated levels of pre-existing comorbidities in that community, poorly controlled chronic diseases, quite an epidemic, lower levels of access to care because there are fewer physicians, severe shortage of primary care docs and of specialists, lowest number of hospital beds per population in LA County, 3 times more diabetes. At a local hospital, the Martin Luther King Hospital in LA County, diabetic amputation is among the most frequent surgical procedures performed. And life expectancy 10 years shorter than the state of California. And part of that reflects the underfunding of care. The average emergency room visit in LA earns $2,000 from commercial insurers, $650 from Medicare, $150 from Medicaid. Medicaid is called Medi-Cal in California. So what I'm saying is that place, again, dramatically affects access to medical care, and it reflects the historic and chronic underfunding of care in segregated neighborhoods that puts populations in those areas at risk for worse outcomes, and it reflects the unequal system that we have in the United States. Research also indicates that when you are low economic status and you live in disadvantaged neighborhoods, you have higher levels of exposure to stress, and not only higher levels of exposure, but greater clustering of stresses. If you have one, you're more likely to have others. Let me give you an example of some of my work with the work of others. We did not a national, but a probability sample of the population of Chicago, of all adults in Chicago, over 3,000 adults. And in this paper, we looked at the levels of stress by population and found that Blacks and US-born Latinos compared to whites had higher levels of major life events, things like the death of a loved one or unemployment, higher levels of financial stressors, like inability to pay your bills, relationship stressors, neighborhood stressors. So across the board, they had higher levels and also greater clustering of stresses. So I've showed the ways in which segregation through multiple mechanisms shapes opportunities for health in the United States. I want to touch base briefly on individual discrimination, that experiences of discrimination are an added source of stress. I had developed back in the 1990s a number of measures of discrimination. The most famous one is the Everyday Discrimination Scale, now the most widely used scale to assess discrimination globally. Over 450 published papers from a meta-analysis one of my students recently did, using the Everyday Discrimination Scale in more than 25 countries, and we find it predicts powerfully health. What is striking about this is this doesn't capture all aspects of discrimination. It just captures one dimension, little day-to-day indignities, being treated with less courtesy and respect, receiving poorer service than others, people acting as if they think you're not smart or they're afraid of you. And just to illustrate it, I'm going to draw on the work of Tenney Lewis, was at Yale University, now at Emory. She's done a lot of work linking everyday discrimination to physiological outcomes. And each line on this slide just indicates a different peer-reviewed paper linking discrimination, adjusted for a broad range of other confounders and risk factors. So higher levels of everyday discrimination predicts more rapid development of heart disease as captured by coronary artery calcification, predicts higher levels of inflammation, higher levels of blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. High levels of discrimination reflects more rapid declines in cognitive function over time. It predicts poorer sleep quantity and quality. One study of population of adults followed over time, everyday discrimination, if you score high on it, is an independent predictor of premature death. These little indignities accumulate and have adverse effects on health. You can see shorter telomere length, visceral fat, dose-response relationship incidence, CVD events. And this is just an example. There are so many studies documenting its negative effects. And research is indicating that these adverse effects begin early in life. Here's one example that used the everyday discrimination scale, measured it on pregnant women, and found that those who scored high on everyday discrimination while they were pregnant, they document high levels of inhibition and separation problems at 6 months and 1 year, and high levels of negative emotionality at 6 months and 1 year. So we've seen long-term adverse impacts of exposure to discrimination. Another colleague I've collaborated with, Naomi Priest from Australia, this is her work looking at a study of Australian students. The average age was 11 years old. Almost 2/3 of them were Indigenous or ethnic minority. And she finds that if they scored high on not the average, a different measure of discrimination, 2 or more incidents, increased BMI. This is at 11. Increased BMI, higher waist circumference, high systolic blood pressure, high levels of inflammation. So again, we are seeing negative effects of these little indignities mattering for health outcomes. There are also hidden ways in which stressors linked to race and racism adversely affect health. I'll give you a couple examples that matter for mothers. Here is a study that found that over 70% of Black mothers in America were very concerned that their children might be harmed by the police. What is that burden of stress these mothers live with every day? And here is a study published just last year of over 3,000 mothers in 20 cities, the Fragile Family Study, and found that 23%, almost 1 in 4 urban youth had been stopped by the police by age 15. And mothers of youth who were stopped by the police are more than twice as likely as other mothers to report both depression and anxiety-related sleep difficulties. So we are documenting adverse impacts on maternal health linked to what is happening to their children in the United States. And the consequences of this cumulative exposure to discrimination and other stresses is linked to what some researchers call accelerated aging, some are calling premature aging. Arlene Geronimus calls it weathering. But it's the pattern of the earlier onset of chronic disease. In other words, your age doesn't only capture how long you have lived. If you live in a bad environment, your age is also capturing how long you've been exposed to bad environmental condition and how physiologically compromised you have become as a result of such exposures. And Arlene Geronimus' important work powerfully illustrates that. I'll give you one quick example. The earlier onset of high blood pressure, you can see at every age. So let's look at age 50 to 64. 61% of African Americans have high blood pressure at 50 to 64, compared to 41% of whites. But some studies have found that at midlife, Blacks and whites at the same chronological age, depending on what indicator of biological aging is using, the African Americans who are the same chronological age as their white counterparts in some studies are 10 years older, their body is 10 years older, or 7.5 years older in some studies. There's studies looking at telomere length and other markers of physiological function. Okay, so we've talked about structural racism, we've talked about individual discrimination. I just want to touch base briefly on the discrimination deeply embedded in the culture that shapes our assumptions, our stereotypes, that also matters profoundly. They trigger discrimination that can lead to reduced access to societal resources. This is the Unequal Treatment Report, a landmark report from the National Academy of Medicine, was the Institute of Medicine called in those days. Back in 2003, this report was released. I served on the committee that produced that report. And what it found was across virtually every therapeutic intervention, Blacks and other communities, populations of color, receive poorer quality care. It was not about access to care. Given access, what's the quality of care? They receive poorer quality care. I could talk an hour on that, but we don't have the time. I just want to give you a recent study that suggests this problem may not have gone away. This is a PNAS paper in 2020, a study of 1.8 million hospital births in Florida. When cared for by white doctors, Black babies are 3 times more likely to die than white newborns in the hospital. The disparity cut in half when Black babies are cared for by a Black doctor. Doesn't tell us all the drivers and what the factors are, but it suggests we have a huge problem. So what can we do? First of all, we have a huge shortage of underrepresented minorities in the health profession. So I'm showing you 5% of medical doctors in the US, 2019 data were Black, 5.8% Latino. If you look at dentists, 3.8% Black, 5.9% Latino. Nurses, this is registered nurses, 7.8% African American, 10.2% Latino. Pharmacists, 7.6% African American, 4.7% Latino. So we did this underrepresentation, and for any of these statistics, if we looked at the Native American population, is less. So you're looking at 0.2%. Sometimes the data is so low it's not even reported because the numbers are that low. So why does diversity matter? Well, diversity is linked to improving patient engagement and the quality of healthcare. So one of the strategies is to diversify the workforce to meet the needs of all patients. Here's a randomized controlled trial done in Northern California. Took African-American men, send them to a clinic, give them a coupon and send them to a clinic for a Saturday morning screening. When they got to the clinic, they were randomized to see a Black doctor or a doctor of a different race. And what the study found is that those African-American males who saw a Black doctor, it was racial concordance, were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get a flu vaccine, more likely to do a screening for cholesterol. So you can see greater engagement with healthcare and benefiting from the resources when there was, in fact, racial concordance. Another study from Northern California gives us some optimism that there are things we can do to make a difference, even if you can't increase dramatically the numbers of doctors overnight. By the way, in passing, that was mentioned, it was a report from the Association of American Medical Colleges in 2015. And what it found was that in 2014, there were fewer African-American males in the first year of medical school than in 1978. So we have a huge challenge when we're talking about increasing the number of underrepresented minorities. But here is this study from done by researchers in Northern California. What they were looking at was patients with HIV/AIDS and the quality of care that they were receiving. And they found there were racial disparities in the receipt of the appropriate treatment. There were racial disparities in self-efficacy and following through on taking the medication as they were supposed to do it. And there were racial disparities in the medication actually working to produce the results it was supposed to do. However, when they divided the providers by those who were high on a measure of cultural competence and those who were low, regardless of the race of the provider, there were no racial disparities when cultural competence was high. It doesn't tell us how to get to cultural competence, but I'll show you the items on the scale, and it gives us a sense of the kind of provider that is high on cultural competence. Providers high on cultural competence, the providers who agreed that friends and family is important to health as doctors, who agreed that social history contributed to how they care for their patients, who agreed that they were familiar with the lay beliefs their patients have, which means you have to ask the questions about it and have a conversation with them about it. Providers who said, I ask my patients about alternative therapies they use. Providers who said, I find out what my patients think is the cause of their illness. Providers who said, I involve my patients in decisions about their healthcare. So you see a high level of engagement, respect, communication taking place, and in the face of when those conditions existed, there were in fact no racial disparities in health. Why diversity matters? I talked about improvement in care. Well, there's research, there's evidence, studies that show it leads to greater creativity and innovation when there are diverse teams at work. Diversity can enhance creativity and innovation. Even experimental evidence reveals that groups with racial diversity significantly outperform groups with no racial diversity. Bringing people of different backgrounds and different perspectives enhances diversity and innovation. Here's a study published in Scientific American some years ago that documented greater diversity of even a research team leads to higher impact papers. And they quantified, a lot of papers, 1.5 million scientific papers they studied, and found greater diversity of the research team leads to higher scientific impact scores. And there is research that also indicates that higher levels of diversity even changes the questions that are asked. Because one of the ways in which the scientific enterprise is affected by the assumptions and biases of individuals is by determining what questions we ask. and what questions we don't even ask. I remember back in 1992, giving a talk at a National Center for Health Statistics conference, and I was one of 4 underrepresented minorities. You know what these conferences where there was a Black person, a Latino person, an Asian American person, and a Native American person, and we were supposed to comment after the end of this 2-day conference final panel. What are the priorities for research? And I remember saying one of the most important priorities is we need to really document the ways in which racism affects health. And a gentleman raised his hand and said, Dr. Williams is right about the importance of racism, but what he's asking us to do, we cannot do. We will never be able to measure racism, so it's impossible to do what Dr. Williams is saying. And I remember saying to him, if you ask me today, do we have valid and reliable measures that we can use? I would say no. But I said, we measure self-esteem. If we measure self-esteem, why on earth can't we measure racism? We just haven't put our minds to it. But the point I'm making is where we sit and our backgrounds determine what research questions we ask and which questions we leave unasked. What does it take to be successful in diversity and inclusion? Now, everybody is into diversity. Every Fortune 500 company, most academic institutions are doing things to promote diversity. There are hundreds of studies. And this is a paper from one of my colleagues in sociology, actually. He's the chair, Frank Dobbin, the chair of sociology department. And what his review finds, and he's reviewing reviews of reviews, the science is overwhelming. Little positive effects of diversity training programs on the careers of underrepresented minorities and women. Just these trainings that are being done by everyone don't seem, this is a review of over 900 studies, found little evidence that even diversity training reduces bias. So here is a study, 400 studies of implicit association. You go to an implicit association test workshop, a 1-hour, 2-hour program on learning about implicit bias. Very weak effects on reducing explicit bias. It does raise awareness. I'm not saying it's useless, and I'm not saying it's unimportant to do, but that alone does not do much to change the underlying problem. However, there is research that indicates that implicit bias can be reduced under certain conditions. And the first one I'm going to talk about is a study done in the UK. Randomized, double-blind, parallel group, placebo-controlled design. Excellent scientific quality. 1 dose of a beta blocker eliminated implicit bias in the healthcare providers for the next 2 hours. Now, I don't think this is a really important study. I don't think it provides a solution. We cannot medicate the world's population for the rest of their lives. But importantly, we live in an era where even powerful political leaders have said an implicit bias is fake news. The fact that we can intervene on it with a pharmacologic agent suggests there are fundamental processes in the brain that are operating. This is not fake news. These are real phenomena that can be intervened on with a pharmacologic agent. So that's why I think it's important. However, psychologists have studied multiple strategies that can be used to reduce implicit bias. I'll talk just briefly about individuation. All of us process all the complex cognitive information we face each day using social categorization. We put things into categories that simplifies our life, makes us just easy to navigate society. But the problem with that is every culture, every community has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. I like to tell my students, I think of myself as a prejudiced person. And I tell them, I think of myself as a prejudiced person because I think of myself as a normal human being. And I said, if you are a normal human being, you're probably prejudiced. I'm saying, no, I'm not saying you're racially prejudiced because it's not just about race. It's about how we process information. And I may not be racially prejudiced, but I say to them, what are your deeply embedded unconscious beliefs about fat people, about gay people, about poor people, about women, about old people. You get the point? About people from this country or that country. That's how we have all been socialized. And individuation says, what happens is, in less 1/3 of the time it takes, blink your eye for me, everybody, just blink your eye once, okay. In 1/3 of the time it takes to blink your eye, studies show when you meet someone, you quickly notice what social categories they belong to, and you will treat them based on those social categories. And if based on your socialization, they belong to a social category you have negative beliefs on, you will treat them differently. That is, you will discriminate against them. It's unconscious. You didn't intend to do it. It just happens. Individuation says, instead of using social categorization, when I meet someone, I'll try to understand that person as an individual, who they are, and not this means the age, not based on their age, not based on their gender, not based on their race or some other social characteristic that is important. A model program that has worked, I call it the Divine Intervention. Professor Patricia Devine from the University of Wisconsin-Madison has developed a program. It's not a 2-hour or 1-hour program. It's a 12-week program. People come every week. They get homework assignments. There's practice exercises they do. And this program works to reduce implicit bias. And she shows that, yes, one Black individual can be motivated to increase their awareness, to increase their concerns, to implement all of those multiple strategies, and that they are effective in reducing implicit and explicit bias. So it can be done, but it takes much more work than what is typically done in both academic and corporate sectors in the United States. So the bottom line is, in isolation, diversity training alone is not effective. It's a step, but it begins to raise awareness levels, but you have to go beyond that. There are a number of promising strategies. One is we need inclusion of practice exercises that include effects to increase interracial or intergroup contact with persons from other groups and increase empathy. I'm going to comment on empathy briefly. We need research that includes helping people to understand moral licensing. What research by psychologists indicate that people who have taken a diversity program and took an implicit bias test, they now feel they don't have a problem, and they're actually more likely to treat persons differently because they feel they are now educated, and that's not a problem, that is a challenge for them. Training alone will not change the workplace environment without larger organizational changes. So it's not just what we do in a workshop, it's what do we do as an organization, as an institution. Multidimensional diversity in initiatives that include not only implicit biases, but structural discrimination is important. Recruiting decision makers to be active in finding solutions. So organizations where this works in the corporate world is those that get managers to meet regularly and look at the data and think of what can we do to solve it. So when the leadership sees it as important and is looking for solutions, it works. The training must be inclusive. That means it must be friendly to everyone. All of us have diversity challenges. It's not only white people have diversity challenges. All of us have diversity challenges. So it has to be inclusive of men and of whites. We need framing that encourages feeling the training is voluntary. Research indicates that for many institutions that make it mandatory, some people rebel and fight against it. So there is a number of dimensions that are important. Okay, I want to just quickly talk about the centrality of empathy. W.E.B. Du Bois, very influential social scientist of the late 19th century, published a book in 1899 on the Philadelphia Negro. He has a chapter on Negro health. And the chapter on Negro health has tables of statistics showing Black-white differences in Philadelphia on a range of health outcomes. As he comes near to the end of the chapter, he pens these powerful words. He says the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he goes on to say there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. So he says the fundamental problem why these disparities exist is what he called the peculiar indifference. That's another way of saying we just don't care that these disparities exist in the first place. And what he called the peculiar indifference, scholars today call the empathy gap. And research documents that there is an empathy gap. This is a review paper that reviews work on the empathy gap and finds it throughout Europe, Africa, Asia, and the US. We feel the pain. We feel more compassion for what is happening to someone of our group than someone of another group. And this review was not of studies, there's self-report data documenting the empathy gap, but these are studies that was looking at brain activity in response to seeing the suffering of someone else. And they were just varying whether the person is of your racial group or of a different racial group. So it's a profound effect. What's even more disturbing is this study that shows, this study showed kids watching, and they would just vary the pictures, a Black person, a white person being stuck in their arm with a needle, and ask the kids how much pain they think the person is feeling. At age 5, these mainly white kids demonstrated no racial bias. By age 7, they tend to see the white person suffering more pain than the Black person. By age 10, it is pronounced. So this empathy gap seems to emerge very early in life. The review paper documented a number of factors that reduces the gap in empathic brain activity. We go back to individuation again. It's people who look at individuals, try to see someone as an individual, not the social groups to which they belong. When people see themselves as members of the same team, we're working together to accomplish the same goals. Experiences of greater interracial socialization, interaction, in your socialization seems to also play a major role. But so there's a lot of we can do. Well, what works? What can we really do? Are there good examples of institutions that have done great success in diversity? What are the keys to success? One is you have to transform the organizational environment. It's not just the workshops and the training. And one of the key principles that's been identified in the field is the importance of psychological safety. And that is creating an environment where everyone, regardless of their background, feels acknowledged, appreciated, treated fairly, respected. And there are strategies that can be implemented to do this. People feel that they can express what they think without fear of being penalized or viewed as incompetent or different or hurting their career prospects. So there are lots of things we can do to be proactive in increasing psychological safety, increasing minority representation, supporting diversity-related initiatives, hiring from diverse sources, implementing the development for diversity management, high quality relationships. Again, leadership is really important. Psychological safety is important for everyone in an organization, but especially so for minorities. I want to give you a case study. This has been studied by people in the field. The Michigan Mandate was a program implemented by the University of Michigan over a decade. It's widely regarded as one of the most comprehensive diversity initiatives ever implemented by a predominantly white research university in the United States. It was developed by James Dunderstadt. He was the provost of the university. He chaired a campus-wide committee that developed the plan. And the next year, he was the president of the university. And he went ahead in 1988 and implemented the plan. He called it the Michigan Mandate. This is Dr. Dunderstadt. He would link diversity and excellence as the two things in almost every talk he gave. He talked about the importance of diversity and excellence in Michigan. Those were the two overriding factors. So again, what people think of were the keys to his success. 3, strong leadership at the top. And it was clear that this was a high priority for the president. Number 2, he put in place a committee that could have an impact. I was asked once at a certain institution, I will not name, to serve on the diversity committee. A staff person came and asked me, and I said, who's on the committee? And what budget does the committee have? What does the committee know? It was a group of staff and students getting together. I said, I don't have time to waste. I mean, I'm supportive of what you're trying to do, but you can't accomplish much. So this was a committee of the second highest ranking official. That means the academic dean of the law school, of the medical school, of the college, of the school of social work, of every unit of campus. So people who could make the difference were the committee that would meet regularly to look at the data and make recommendations. And third, and most importantly, he allocated 1% of the entire university's budget into an escrow account that could only be used for diversity initiatives. So if you wanted to implement, you were chair of a department, the dean of a school, you wanted to implement 1% for university budget is a lot of money. You wanted to implement diversity initiatives, you wanted to try out something new, there was money to do it. And the results of this program, by the 1990s, minority student enrollment more than doubled, marked increase in minority faculty, success of minorities improved with graduation rates rising to the highest among public universities, promotion and tenure success of minority faculty increased appointments of minorities in leadership positions. It's a dramatic success. The tragedy is things today at the University of Michigan, a school that I attended, and was a faculty member of, worse than they were before the Michigan mandate was implemented. Because it takes staying power. Dunderstadt was the president for 10 years, and he's no longer the president. It didn't last. I want to talk about the importance of mentoring. I want to give you time for the conversation, so let me try to wrap up here quickly. And I want to say organizations need to put structures in place that identify, nurture, and mentor the next generation of scientists. Here is one study. Interpersonal discrimination, even in academic environments, increased stress, poor physical health, work performance, but supervisor support is important and reduces some of the negative effects of bias. I say we need to, as we look to the future, we need to learn from the past. I want to talk briefly about myself and my mentors. This was my main mentor, Professor James House, when I was in grad school. I am, I like to say, an affirmative action baby. Without affirmative action, I could never have matriculated at the University of Michigan. And I think without a mentor who really cared, who went out of the way, we did a celebration. I was one of the organizers of it 4 years ago for Professor House when he retired, and brought back more than 50 students and postdocs and who he had trained over his career. And they were 90% were either minorities or women. He went out of his way to make a difference from others. And I thank him for what he's done for me. But it takes a village. I want to talk about 3 other people who were not my primary professors, but who gave me key mentoring advice at critical moments. Professor Norman Miles, who gave me advice in going to graduate school. I was a public health educator working in Battle Creek, Michigan. I was planning to do a PhD, and the easiest thing for me would have been to go to Western Michigan University. It was really close. I wouldn't need to move. And I thought, I would go there. And I ran into him and he asked me, "What are you doing? What do you plan to do?" I said, "Well, I'm planning to go doctorate." And he says, "Where are you planning to go?" I said, "Well, Western Michigan University is really close. I could go there. If I'd gone to Western Michigan, you would never heard of me." It's the truth. He said, "You have to go to the University of Michigan. This is one of the strongest universities in social sciences in the world. And it's an hour and a half away. You can move. That's no problem." Without his very definite advice, at a critical moment in my life, my whole career would have been different. Professor Alden Morris was a faculty in my department at the University of Michigan. He's now a professor at Northwestern University, scholar of W.E.B. Du Bois. And I was in my last year of graduate school. I was applying for jobs. I saw a position at Yale that wanted someone with my specialization, and I didn't apply for it. I think call it imposter syndrome. I thought Yale is never going to be interested in me. So I didn't even apply. And I'm walking down the hallway, and Professor Morris just happened to run into him. He said, "Oh, I just talked to someone at Yale. You're going to be hearing from them." I said, What? He said, "Well, they have a job." And they were asking who was good coming out of Michigan. And I gave them your name. And I said, "But I'm not going to go to Yale. It's got too much pressure. I just want a nice, quiet school where I can do my work and without the pressure." He said, "David, let's go to lunch." And the next week, he took me to lunch and sat me down, explained how academia works, and explained, "You train at Michigan, you're going to have a lot of pressure anywhere you go. So go to a place which gives you the resources to deal with the pressure," and shared some of his own experiences. I applied to Yale, got the job, and I started my career as a professor at Yale. But without Alan Morris's quick hallway conversation, I wouldn't have done that. And finally, Professor James Jackson, who died about 2 years ago, who has trained more scholars of African descent in the social sciences than anyone else. Ran the program for research on Black Americans since 1978 until his death 2 years ago, and was just a phenomenal colleague. And I went back to Michigan as a tenured faculty member, and he took me under his wing. And even my work with the everyday discrimination scale, he went out and raised the money to get the funding to do the study, the first study where we would use a scale. He was just an amazing mentor. So it takes a village. It's not just one person. It takes a village to do it. Take-home lessons. What works best? Begins with needs assessment, visible top management support. I took longer than I planned. Rewarding efforts to promote, rewarding efforts to promote diversity. Making diversity and inclusion a part of the mission, long-term commitment, ongoing evaluation, responding to employees' concern. I also want to touch base quickly. I'm going to end in 2-3 minutes because I need to end. There's a lot we want to discuss. We also need to provide care that addresses the social context. The World Health Organization asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick? And this is a National Academy of Medicine report that has a number of ideas of how we can integrate social care into the delivery of healthcare. 2 examples. The Medical Legal Partnership, born in the Boston Medical Center in the pediatrics unit, Professor Zuckerman, Dr. Zuckerman, a primary care provider at Boston Medical Center can refer people to a number of specialists. One of the specialists is a lawyer. The hospital has on-site lawyers to solve the problems in the lives of their patients. Because if a mother brings a child and has asthma, secondary to the poor housing conditions, all the asthma and medication in the world will not help that child to be symptom-free if the child goes back to live in the same conditions. A nurse-family partnership model is another example of taking the social context and intervening comprehensively. A long-term strategy, we need to create communities of opportunity. We need to enrich economic neighborhood environments, housing quality. If segregation creates these conditions, we have to dismantle those structures. We need to create communities of opportunity. Many things we need to do, reduce childhood poverty. The Abecedarian Project is one example of early childhood development that randomized control trial took poor kids, 80% of them African-American, put them in a high quality nurturing environment, birth through 5. And by age 21, by age 21, they're doing better in health, they're doing better in education, they're doing better in job prospects. By age 35, they're doing better on a broad range of indicators of metabolic disease. We also need to implement policies to reduce childhood poverty. We talked about the centrality of childhood poverty. Here is a study from UNICEF that shows the levels of child poverty produced by different societies. In Ireland, 42%. The economy produces a child poverty rate of 42%. But after taxes and transfers, after that society implements its policy preferences, childhood poverty is reduced to 8%. And you can see in other countries. US, the economy produces a 24% child poverty rate. After our policy and preferences, it's gone to 23. We're not doing anything to help our kids. I want to say a walk down memory lane. We need to keep the social safety net in place. Look at what happened in the Reagan administration, first year, 1981, massive cuts in social spending. And what were the impacts? Increase in low birth weight in the United States, decline in infant mortality slowed, over 250 community health centers closed, infant mortality increased in poor areas in 20 states, increase in the number of women not receiving prenatal care, increase in anemia among pregnant women, new cases of measles increased for the first time since 1963, just quickly within 2 years of a massive cut in the social safety net. So we need to think of our principles of new intervention. We need to think not only of the kids, we need to think of protection and enrichment of the family environment and resources for families, improving parent skills, thinking of strong communities. All of those things are important. There are initiatives from one last example, Rush University Medical Center, an academic medical center. It decides it's going to reduce the life expectancy gap from the poor communities it serves to the wealthy communities it serves within 10 years. And look at what they're doing. A broad range of initiatives to enhance economic development at the local level as a strategy to improve overall population health. My last point is if we create these communities of opportunity, we're not only helping populations of color. There are more poor white people in America than poor African Americans or poor Latinos. So if we implement these strategies, they will help all vulnerable populations. I leave you with the words of Nelson Mandela. There can be no keener revelation of a society's soul than the way in which it treats its children. Thank you so much for your time and attention. Sure, there are questions for me. I'm not sure how we're going to handle that.
No, I think we didn't really discuss. I think we can take questions from both, hopefully from both the room and from Zoom. I think we can start in the room and then take in sort of turns. There should be questions. There are microphones on your table. I don't know if you have to turn them on, but please use them. Raise your arm and
Leave it on.
leave them on. So are there any questions for David?
Don't all speak at the same time. Questions or key comments, briefly?
Welcome.
Okay, any from online, maybe? They might be ready.
Or in the chat.
In the chat.
Somebody monitor the chat. Destiny.
Can you hear me okay? This is from online.
Yes, we can hear you.
Okay. Thank you for that, obviously, tour de force and highly illuminating and also inspirational, if not sobering, talk, Dr. Williams. I'm trying to reconcile a little bit that econometric paper you cited early on that seemed to conclude that eliminating segregation was the answer, and that if we could do that, then the racial disparities would be eliminated. And yet, you addressed in the rest of your talk seemingly a number of additional strategies, none of them panaceas for sure, as you articulated, but nonetheless important, such as anti-bias training and other kinds of more structural tax and income transfers, as you noted in the conclusion. So I'm doing this mental experiment on the one hand of moving people and mixing them together, and on the other hand thinking that's not going to be sufficient, even if the analysis, if I understood it right, is indicating that. So I'd love to hear your thoughts on that.
Sure. Thank you so much. That's a great question. So what the study didn't conclude per se what we need to do. It showed what are the drivers of the racial inequities. And it shows statistically it's processes linked to segregation that account for them. In theory, you could think of one of two ways that this could be, a problem could be addressed. One way would be to, in fact, create integration, eliminate segregation as it exists. Alternatively, theoretically, I'm not sure that is practical or realistic from everything else that we know, but alternatively, you could think, how do we dismantle the conditions that segregation has produced? And if you could eliminate those conditions, it's really, if you want to think of it, let me put it this way. There is nothing inherently negative about living next to someone of your own race. So the problem of segregation is not segregation per se, but it is the clustering of social ills, what William Julius Wilson calls the concentration effects that exist linked to segregation. So I'll give you a statistic. What research Gary Orfield, who's done a lot of work on segregation in education and was a faculty at the School of Education here years ago, what he shows that in metropolitan Chicago, the correlation in elementary schools between percent poor and percent Black and Latino is 0.90. You know percent poor, you know percent Black and Latino. If you are an elementary school teacher, it makes a difference. And what Gary Orfield's work also shows, there were, at the time of his work, there were more poor white kids than poor Latino kids, and more poor white kids than poor African-American kids. But most poor white kids went to schools where the majority of the kids were of middle-class background. Most poor and Black and Latino kids went to school where the majority of kids are poor. Imagine yourself in an elementary school teaching a class with 25 students. It's a very different scenario if 5 of the students in your class are poor than if 20 of the students in your class are poor. If 20 are poor kids bring more social problems to school, and you are now not just a teacher, you're a social worker because of the problems they bring. So it's how can we eliminate the factors linked to segregation that is wrapped up with the concentration of poverty. But so in theory, if we could break those linkages and create economic development at a neighborhood level, create opportunities at a neighborhood level, that would be a viable solution. The question is, practically, can we do it? I am not an optimist that we can do. I'm an optimist in general, but I'm not an optimist that we're gonna do it. Just looking at human nature and how we always look out for what is good for us. If you have the time, there is a New York Times article trying to think. We are probably in November of last year, November, December, late last year, of Minneapolis, Minnesota, which is a community that over 80% of the voters voted for Joe Biden, Democratic. And it talked about in the wealthy communities around Minneapolis. Most on their lawns have Black Lives Matter signs. So this is a very progressive community. But the school district tried to do something dramatic and tried to desegregate the schools and redrew the boundaries. And so that a school that was 90% African-American would now be 50% African-American, 50% white, by the way they had redrawn the boundaries. And they showed the upheaval that took place. It did not work because white parents from the wealthy neighborhoods did not want their kids going to what school was historically Black, even though the school district was putting more money in the schools and increasing the number of language courses and doing all these things. I mean, it's worth reading. I don't remember the title of it, but probably residential segregation in schools in Minneapolis late last year, a lengthy New York Times piece, shows the challenge, even with people who are very progressive. Larry Bobo is a colleague of mine here at Harvard University. He's done a lot of research on racial attitudes and prejudice. And one of the things he talks about is laissez-faire racism. And what he means by that is that there are a lot of progressive people in America who want to see inequality eliminated, but without any cost to them. So if you can go ahead and eliminate inequalities, even though the structures that have put in place have produced them, you don't want to see the structures change. But if you can go and do it, God bless you. Yes, go right ahead. But I am not going to pay any cost to ensure it happens. So given that kind of reality, I'm not sure how much progress we can make. There are examples. I often talk about purpose-built communities as a model. You can Google it. Purpose-built communities, their stuff. East Lake, Atlanta was the first example. It's in many, about 20 purpose-built sites in different areas that have had a dramatic ability to take poor African-American housing projects. In the case of East Lake, tore down, rebuilt from the ground up. I've visited it with my colleague, Jack Shankov. We spent a day with Purpose Built, and they have just completely transformed a disadvantaged neighborhoods, have a cradle to college pipeline. Kids are doing really well, have a model. They'll provide free technical assistance to any community in the country that wants to do it. But although it has had a dramatic effect for the 3,500 people who live in that community, there's still child poverty in Atlanta. It hasn't changed the face of everything. It has made a difference for that small group. So how do we, replicate this and make it more normative? It's a huge challenge. So you've put your hand on a major challenge we face as a society of how we will build the empathy and how we would be willing to make sacrifices or investments on our part to ensure that we have better outcomes. But thanks for the question, a great one. Another question? Okay, one in the room.
Hi, can you hear me?
Yes.
Hi, this is Alice Crow from the chat. Thank you so much for this wonderful talk. I'm zooming in from UCLA. And I share a little bit of your cynicism as far as the fact that unequal treatment came out almost 20 years ago, and we've almost seemed like we've gone backwards in progress. And one of the reasons for that, I think, is this superficial addressing of being nice to everyone, right? So there was a period of time where being racist was not politically correct. So children and people were taught to hide their true feelings, to say things in a way that were perceived to be inclusive, but really just sort of, hid their true feelings. And then under the previous presidential administration, where it was okay to say those things, I think it really shocked many of us to understand the deep ingrained feelings that many people have. So I worry that this current attention being paid to diversity, some of it is addressing structural issues, but even at my children's elementary school, where there's a no place for hate club, it's more of just being nice as opposed to really understanding, racism. What are your thoughts about that? And do you think that it's better than saying what you really feel, I suppose, but at the same time, in another couple of decades, we may see the truth again?
Really, really important and difficult question for us to answer. What do we do as a society? Yeah, we are in a particular moment in the United States. I would argue, and there's evidence consistent with my view, there would have been no Donald Trump if there hadn't been a Barack Obama. It was Barack Obama's presidency and the discomfort that many Americans felt that a Black man was in the White House that created that vacuum that Donald Trump capitalized on. And there's a lot of evidence. I can't remember the author. There's a review paper in American Annual Review of Sociology that shows the impact, the impact, even some of the things we struggle with at a state level. There had not been as large a loss of democratic power at the state level as in the 4 years after Obama got elected. The governorship changed in so many states. The legislative bodies changed in so many states. There was a reaction to Obama, and the Tea Party capitalized it, and many people who did not belong to the Tea Party shared their views. Research suggests that the driver of opposition to Obamacare was the perception it was a new welfare program for Black people. And there was more opposition to Obamacare than there had been in the public to the Clinton healthcare plan. And research by political scientists shows it can completely be explained by racial prejudice. And Donald Trump capitalized on this. And he can run again, and he could win again. As I shudder to say that, is that possible? I think it is. So we have a problem. We have a problem as a nation. We have a problem. Exactly what do we do about it? I think that we are also becoming so polarized. I like to talk about the fact that we need to create safe places where we can talk. And we don't have them right now. And I criticize people on the left and people on the right. There are people on the left that are so ideological in orientation, so unforgiving in orientation, that will jump and criticize someone severely for the slightest mistake they make, not realizing they don't have all the knowledge and insights and so on that you have. And we need to be a little more patient with each other, a little more understanding with each other. We don't all have the same knowledge and background and information, and we need to create these safe places where we can talk. What it will take to do that, it will take a major transformation to do that. So I think that's fundamentally one of the things we have to do. But you've put your hand on a major problem we face, and I don't know. I think we are literally in this moment at a crossroads as a country.
David, I have a question too. Perhaps more, I know it better about Europe, but you see, I think the same tendency here is a strong trend in the recent years to I don't know how to call it even, but interracial marriage. The US doesn't assess it. It's changing now, but very well, because there's not even in many forms a mixed category. In the UK, there is. They're seeing a huge trend that actually motivated, surprisingly, by internet dating, where people are much more dating outside their own social circles. Some people have said that that is a powerful movement in some cities, even in the US. Will that change anything How do you think, are there any predictions to do anything about that? Or is it something you don't think it's relevant?
It is relevant. The Europe has had much higher levels of interracial marriage than the US has had historically. You have to keep in mind that until a Supreme Court case in the 1960s, in 28 states, interracial marriage was illegal in the United States. You could go to prison for marrying someone of a different race. That's how strong it is. That's the history here. And those beliefs have improved, but work of Eduardo Bonilla Silva said that even a lot of Americans, he did a survey and then he went back with the 20% and did an in-depth interview. And people who say, oh, they support interracial marriage, when you ask them, could you tell me more what you think? And they clearly indicate, well, if you want to do it, it's fine, but I wouldn't do it. I wouldn't want my family to do it. So there's still some reluctance, but no question. I think if you look at young people today, it is happening with enormous opposition from parents often, but it is happening, it is increasing. So I think long-term, it will make a difference, but the progress along those lines are so slow that I don't think that alone is sufficient. I truly think we need a new culture, a new environment where we are willing to listen and learn from each other and create safe places where we can talk. I know my time is virtually up. I see 2 hands. Yes.
Okay. Anything
Yes.
online, Destiny?
Yes, Lindsay has a raise. Lindsay, if you want to unmute.
Sorry, we were going to go back and forth. Just hold that thought. We'll get to both. Go ahead.
I don't know if you can hear me. Lindsay, if you're still on the call, you can unmute and ask your question.
Great, thank you so much. Hello, everyone. Thank you, Destiny. Dr. Williams, thank you so much for your presentation. I've been a fan of your work for a long time, and it was great to be able to hear you speak today. I have a question in regard to those of us that are early career professionals that are thinking about moving into the academy as our full-time pursuit for our career, and the work that you described around diversity, equity, and inclusion or access initiatives. When we're thinking about moving into places in the academy or other institutions, what should we consider in terms of thinking about for the jobs? Like, how should we think about the DEI work that's happening in those institutions? What questions and expectations should we ask as we're going on the job market in regard to the work that's being done and their commitment to advancing equity in their practice? Thank you.
Sure, thanks. I think George Floyd has had a positive impact on diversity in the United States and diversity globally. I have spoken to more major corporations and their boards in the last 2 years than in the prior 30 years of my career combined. So there's clearly interest from non-traditional entities in these questions. So I think it's a good moment for you young people to be coming into the field where people are looking for expertise and looking for knowledge and access. And there's a greater openness to listening and to learning. At the same time, I think, entrenched structures are difficult to change, and it takes real commitment and leadership. So what I would say to young people beginning, the sky's the limit. There's never been as great a time as now, and it doesn't mean that there are no problems, but things are better than they used to be. I think it's important to have good mentors, one, but it's also important to have a good network of support. That you have other like-minded individuals that you can share and debrief with. I debrief with a lot of former students and postdocs, and I could keep you entertained with horror stories that they call me up stressed out about something that happened to them at their institution. So it's still a difficult world out there for many, but I think things are more open now, and I think rely on mentors that you've had in the past, but also establish networks of support of like-minded persons that can make a difference in terms of giving you the kind of moral and social support that you need to succeed. I think there were questions in the room.
Yes.
I'll jump in. So hi, Dr. Williams, Cynthia Minkovitz from Johns Hopkins School of Public Health. So thanks so much for your thought-provoking comments. And you've given us all a really important charge. So while we have differences across our institutions, we're all committed to training the next generation of leaders in maternal and child health. And I wanted to follow up on your comments around the polarization of our society. Given that polarization, we have lots of, sort of leadership competencies that we focus on around reflection and ethics and cultural competency. But what are the skills that we need to be imparting to our trainees across the spectrum to make sure that they're equipped to deal with the polarization and promote the health of populations and addressing racism?
Wow, this is a really good question, really tough question. I don't know that I have all the answers, but let me tell you what I think. I think one, we need to, some of my students are so idealistic. They want to see everything change tomorrow. And they clearly understand the issues, and you don't want to quench their spirit on the one hand, but you have to prepare them for adversity. So that when they encounter adversity, they don't give up. And that's where a network of support, I think, again, can play a role, that they have someone they can share and debrief with, is one of the important strategies. And I actually think, I sometimes say that some of the biggest needs in the area of addressing inequities is that those of us who, this is what we do, this is our passion, this is our work, this is our profession, that we need to do more work with communication specialists, and we need to do more work with political scientists. Because one of the challenges we face is, how do we build political will to do the things that we have? How do we create the empathy I talked about? That is, there's research. There's actually was a study done years ago by Tom Pettigrew, was a US researcher with some European researchers. And they did a national study in England, in the Netherlands, in Germany, and in France. And in each group, they asked people about their beliefs about an immigrant outgroup. And what they found was one of the strongest predictors of policy support, or lack of policy support, was the absence of empathy, the absence of positive feelings towards that group. Two questions: how often you feel sympathy for the group? How often you feel admiration for the group? The lack of sympathy and the lack of admiration, with James Jackson, we replicated that study in the Detroit metropolitan area, and we found the strongest predictor of whites' opposition in metropolitan Detroit to affirmative action for Blacks and to increase government support to assist Blacks was just those two questions: the lack of positive affect, not feeling sympathy, not feeling admiration, was the strongest, and it's stronger than political party IDs, stronger than whether you were liberal or conservative, stronger than income, education, wealth, traditional measures of prejudice. Just tell me how you feel about the group was a strong predictor. So one of the things we need to learn, years ago, I served as a staff director of the Robert Wood Johnson Foundation's Commission to Build a Healthy America. One of the things we did, 1/3 of the budget was spent on communications, working with both a Republican leaning and a Democratic leaning firm, and trying to learn, how do we talk about the social determinants of health in ways that connect with policymakers, in ways that people would understand. And I think there are, I'll give you one example just to make it concrete. We worked with a communication firm that did research for us, and they've told us, for example, the language of one of the things we want to do is to level the playing field. That Democrats like to hear that turns Republicans off. Because when you say leveling the playing field, in their minds, subconsciously, they are thinking you are pulling some people down if you level the playing field. So it gave us, instead of talking about leveling the playing field, use language like creating opportunity for all. Democrats and Republicans both like the idea of creating opportunity for all. But it's just one little example of just what the language is we use can make a difference in terms of how people understand and view things. So there's a lot we need to learn about how we talk about these issues. That's important.
David,
yes, I know.
One last question, because I don't want to eat up the breaks.
Yes. No, I completely understand.
Let's take 3 more minutes for question and answer. So we have 20. That's
Okay.
good. Yeah, go ahead.
No, just.
Is there
I think
anybody
I
online,
saw-
Destiny?
I saw another hand in the room on the
Or
second
did we
table
miss
behind
one
this
in the room who had stood up earlier, I think?
Yes.
Was there a Wendy?
Julie's been waiting for a while.
Yeah,
Yes, I
Julie.
think it's Julie. Okay.
Thank you, Dr. Williams. This may be just another version of questions people have asked, but I was so struck when you used the term the empathy gap. I have a nascent book proposal called The Empathy Gap really on this. So I would love to talk about this. And I was going to ask a version of Cynthia's question as well, is that how can we build this into our curriculum? But I really think about it on a couple levels structurally, how as a society can we do better at really exposing people to people they have not had exposure to? And I think that when we see this on an individual level, people are profoundly changed when they live in environments they haven't lived in, when they have exposures. So I recently relocated from Austin, Texas to Chicago, Illinois, and moved purposely to Texas to try and get some insight onto bipartisan solutions to some of these really interesting and difficult problems. And I have to say that moving back to Chicago, a very blue state, people have said, "I'm so glad you got out of hell," right? And so I have to say that on the left, we're as guilty of being intolerant as many who we are worried about on the right. And so I would think that building tolerance among ourselves, those of us who claim to value tolerance, and thinking about how to build it in our students is really one way. But I also just think about structurally ways that we can organize society a little bit more. There's a great book called The Big Sort, right, about how our society has sorted ourselves into ideological similar. So yeah, I just wonder, I guess my question at the end of all of this is, have we seen good examples? And you've already listed a bunch, but I mean, structurally, policy, ways that we can do this, ways that we can try to reorganize a bit.
It's a good point. I'll say quickly in response to it. What we know that works is narrative. You need stories that illustrates the challenges in a way that people can identify with. And so that's why I talked about, I didn't elaborate, why we need to work with communications experts. So how the challenge we face is, how do we tell the story of the plight of socially disadvantaged groups in this country in a way that the vast larger public can identify with, can understand. And what Frameworks Institute has done some work in the space, and they found that most of the framings we typically use do not break through the dominant assumptions and stereotypes people have. So we're talking, but we're not talking with each other. We're talking to each other, but not with each other. We're not communicating. And so how do we find those stories that really break through, that people can understand it? You have to increase understanding. And we see the American public is a very compassionate public. You see a disaster around the world and people are texting money to help from this tsunami. So, but you see, it's amazing. They saw the story, they saw the suffering, they identify, they respond. We need to figure out how we do that effectively, because if we can have empathy, we can build political will. That's the last question. Thank you so much. It was a nice engagement.
That was so terrific. And you anticipated what we're going to be doing in the next day and a half. So much. You've given us so much food for thought. Thank you. Thank you. Let's break until noon and come back here right on time so we can meet with Dr. Warren and